Hello to the Northwest Kidney Center Dialysis Center staff. We just had a huge blowout party at the Kent unit celebrating our status as a 5-star facility and, of course, firmly establishing our unit in its position of prominence in the history of the Northwest Kidney Center, the first ever outpatient dialysis organization in the world. So, in summary, the Kent unit is the finest unit of the finest outpatient dialysis organization in the world. But not to completely take the limelight off of other Northwest Kidney Center dialysis units, I just want to acknowledge that other units exist, are doing fine work. This month, I'll throw a shout out to the Federal Way East and West dialysis staff for their excellent service and care of our patients. Today, we're going to talk about the pre-dialysis assessment, how to evaluate and examine a patient before you hook them up to the dialysis machine. The pre-dial assessment can be brief but still thorough, and we'll discuss the highlights in today's talk. There are just two objectives of today's talk. First, understand the goals of the pre-dialysis assessment and review the key steps involved in the process. There are 4 goals of the pre-dialysis assessment. Step 1, we want to confirm the appropriateness of the dialysis prescription. So, for example, if a patient has shortness of breath, he or she probably needs more fluid removal, even if they present at or below their dry weight. Second, we want to ensure patient safety, specifically so that we can avoid complications. So for example, if a patient presents with a blood pressure of 250/130, maybe the heparin should be reduced, or if the patient is symptomatic with chest pain or shortness of breath, maybe he or she should be dialyzed in a hospital setting. Third, we want to use the pre-dialysis assessment as an opportunity for education. It's one-on-one time spent with the patient is an excellent opportunity to remind him or her to, say, for example, monitor their access, follow a low phosphorus diet, etc. And of equal importance is the 4th component of the pre-dialysis assessment: establish rapport with the patient. Being on dialysis is scary. It's often accompanied by many negative emotions such as fear and fatigue and loneliness, and spending some time connecting with the patient before dialysis is an excellent opportunity to provide comfort to someone who will likely benefit from it. So let's now review the components of the pre-dialysis assessment. The pre-dialysis assessment can be summarized in 6 convenient steps. We review their vitals, volume status, assess the access, solicit symptoms from the patient, establish rapport, and provide education. Vitals are a great place to start. The term vitals is appropriately named, considering their importance. The name comes from the Latin vitalis, which means of or belonging to life. And as you all know, there are 4 vital signs: blood pressure, heart rate, respiratory rate, and temperature. My assessment of patients, whether in the dialysis unit, a clinic, or hospital, always begins with a review of their vital signs. Blood pressure is particularly important because it is a clue to the patient's volume status. They say that the eye is a window to the soul, while blood pressure is a window to someone's volume status. And achieving what we call euvolemia, or having a normal amount of fluid in the body, is one of the main purposes of dialysis. Now, if a patient presents with hypertension, they almost always are volume overloaded. So if your patient presents at or below his or her target dry weight and is hypertensive, then the dry weight is almost certainly wrong and needs to be lowered or challenged. Recall that dry weight is the body weight at the end of dialysis at which the patient can remain normotensive until the next day without antihypertensive medications. That is, it's the ideal post-dialysis weight that allows for normal blood pressure. In the vast majority of dialysis patients, hypertension reflects volume overload or too much fluid in the circulation. On the other hand, if a dialysis patient has low blood pressure at the start of dialysis, there are a few likely considerations. If they've recently had nausea, vomiting, diarrhea, volume depletion is possible. It's easy to figure this out just by asking the patient. If the hypotension is chronic, the most likely cause is heart failure, as a poorly contracting heart does not squeeze vigorously and therefore does not generate as much pressure in the arteries as usual. So heart failure is a very common problem in the dialysis population, with a prevalence of at least 30 to 40%. Another consideration regarding cause of low blood pressure is infection, which is the second most common cause of death in dialysis patients. A patient could have an access infection, particularly if he or she has a catheter, or a graft infection, or a fistula infection, particularly if the patient uses the buttonhole technique of cannulation. Pneumonia is also common among dialysis patients, among other forms of infection. Heart rate is another important vital sign. If a patient has bradycardia, defined as a heart rate of less than 60 beats per minute, the most common cause is hyperkalemia. Now, other common causes include medications such as beta blockers, such as metoprolol or carvedilol, or the alpha agonist midodrine, which is often prescribed to dialysis patients who have frequent intradialytic hypotension. On the other hand, if the patient is tachycardic, defined as a heart rate greater than 100 beats per minute, there are several considerations. Arrhythmias such as atrial fibrillation are 2 to 4-fold more prevalent among dialysis patients than the general population, and are present in about a third of dialysis patients above the age of 70. Volume depletion, again, which is usually easy to tease out historically just by asking if they've had vomiting or diarrhea or poor oral intake. And finally, infection. Infection can cause low blood pressure, but can also cause tachycardia because the body mounts a stress response in which catecholamines or stress hormones such as adrenaline are produced, and these hormones increase contractility, blood pressure, and heart rate. Pay attention to someone's respiratory rate. A fast respiratory rate is called tachypnea and is defined as breathing more than 20 beats per minute. By far the most common cause of tachypnea in a dialysis patient is volume overload. If a patient is short of breath, even if he or she presents at or below the assigned dry weight, then it is important to remove fluid and challenge the dry weight. Another cause of a fast respiratory rate in a dialysis patient is having too much acid in the blood. So normally the kidneys get rid of acid waste products from the blood, but when the kidneys don't work well, the acid in the blood accumulates. If a dialysis patient has too much acid in the blood, which is common, particularly if they've missed 1 or 2 dialysis sessions, then the patient will breathe faster in an effort to try to exhale more acid in the form of carbon dioxide. Now, a low respiratory rate, or bradypnea, is defined as breathing fewer than 12 breaths per minute. Most common cause is medications, most notably opioids. So if you have a dialysis patient who takes chronic pain medication and has a low respiratory rate, they're almost certainly taking too much pain medication. Last vital sign is temperature. Pay attention to fever. Fever is defined as a temperature greater than 100.5 degrees. Most common cause is infection, which we just discussed, and may include an access infection, pneumonia, diabetic foot infection, among other causes. Fever nearly always necessitates blood cultures, often empiric antibiotics as well. And in general, if a dialysis patient has a fever, then we would also refer him or her to the hospital for further evaluation. If the person is hemodynamically stable, it's usually more practical to complete the dialysis treatment before sending him or her to the hospital. The second part of the pre-dialysis assessment relates to volume status. So volume refers to an accurate assessment of how much fluid the patient has in his or her circulation. It's an important part of the dialysis prescription. Specifically, when we dialyze a patient, we always ask ourselves, how much fluid should we remove from that patient during that treatment? As I mentioned before, and as you all know already, fluid overload is a very common and important complication of patients on dialysis. It causes shortness of breath, it leads to increased hospitalization and mortality. So it's very important that we do a good job assessing people's volume status. There are several signs of volume overload to look for in physical examination. Probably the easiest one is lower extremity edema. If patients been lying down for a long time, some of that fluid can redistribute to the hips or upper thighs. But when they first walk in, if they're able to walk, you should see the edema in the lowest part of the leg because we live in a world with gravity. Take time to also look at their neck veins. We look for something called jugular venous distension or distension of the neck veins in the neck, specifically the jugular vein. If the neck veins are visible, particularly with them sitting in the upright position, it almost always means that they have too much fluid inside of their blood vessels. Shortness of breath is a common finding in someone with volume overload. Pay attention to the breathing as they walk to the dialysis chair. Are they huffing and puffing? Are they short of breath with exertion? We call that dyspnea on exertion. Dys means difficult, and the root word pnea refers to breathing. So difficult breathing with usual activity. Very common complication of volume overload. Most patients with congestive heart failure report dyspnea on exertion. Another common symptom associated with volume overload or heart failure is orthopnea. Ortho is a Greek word for straight, and pnea means to breathe. So really it refers to breathing when you are straight or flat in bed. Shortness of breath that occurs when lying down usually refers to fluid in the lungs, and it's relieved when the patient sits upright, and then gravity takes that fluid out of the lungs, below the diaphragm, and into the legs. So if your patient says he or she has difficulty sleeping at night or has to be propped up on a number of pillows to breathe comfortably, that is also a sign of or a symptom associated with volume overload. People with volume overload often awaken from sleep with difficulty breathing. We call this paroxysmal nocturnal dyspnea. Again, it's a sensation of shortness of breath that awakens people from sleep, usually 1 or 2 hours after sleep, and is usually relieved in the upright position. A more subtle but common finding of volume overload in dialysis patients is a frequent cough, particularly at night. It often interferes with the ability to sleep, and it reflects fluid that's in the lungs as a consequence of mobilization from the legs when the patients lie down. Again, when you lie down, gravity is no longer keeping fluid out of your lungs, and it can mobilize from the legs back into the lungs, cause pulmonary edema or congestion, and this can cause a cough. The lung exam may also offer clues to the patient's volume status, particularly in the setting of volume overload. If a patient has crackles or so-called rails on exam, these are Velcro-like sounds that tend to occur mainly when the patient takes in a deep breath, and it's thought to opening of previously closed airways. The patient might also have diminished breath sounds, which could represent fluid in the lungs called a pleural effusion, as seen in this chest x-ray. Patient may also have wheezing, so pulmonary edema or fluid in the lungs sometimes presents with wheezing or so-called cardiac asthma. So not all wheezing is asthma or COPD. When you listen to the heart, it's important to listen with intention. You're listening specifically for something, not just to find out whether the heart is beating, but you want to listen for, first, an S3 heart sound or a so-called gallop. It's a third sound that occurs right after the second heart sound, and it basically is produced when a large amount of blood strikes a compliant left ventricle. So it's something that's seen in patients with heart failure or volume overload. So if this is a normal heartbeat, then this is a patient with an S3. Okay, it's also good to listen for a murmur. Murmur represents a disturbance of blood flow primarily due to someone with a heart valve problem, something like aortic stenosis, which is a narrowing of the valve, or sometimes regurgitation. What does a heart murmur sound like? It sounds actually pretty similar to what a fistula sounds like. Whoosh, whoosh, whoosh. So you all are pretty familiar with that sound. And finally, tachycardia. Someone with a fast heart rate it's commonly found in the setting of volume overload. Again, if you are in heart failure, if your heart is having to work harder because of volume overload, then the body produces stress hormones that raise the heart rate. The next important step in the pre-dialysis assessment involves inspection of the access. It's the first step in diagnosing an access problem, and we approach the physical examination of the dialysis access as we do with any organ system in the body. Look, listen, and feel. First step is just look at the access. A vein greater than 4 millimeters predicts 89% cannulation success. We also want to examine the skin for redness, which could represent infection or a reaction, say, to a sterilizing agent such as chlorhexidine or betadine. Look for aneurysms or a bulging, thickening of the skin, which could increase the risk for bleeding. Thin, shiny skin overlying an aneurysm is a sign of potential rupture. Swelling of the axis arm could represent a problem with drainage of blood from the arm, which is often seen in the setting of stenosis or a narrowing of the dialysis fistula outflow vein. If you see a bunch of collateral veins, think central stenosis, because the blood is trying to return through the vein, but there's an obstruction, and so it forms new pathways for the blood to return to the heart. Compare the two hands, the one axis arm hand with the non-axis arm hand. Look for a cold blue hand, frequently seen in elderly patients or patients with peripheral vascular disease, and it's more commonly found in patients with upper arm fistulas compared to radiocephalic fistulas. An examination of the scar on their axis arm can tell you what kind of fistula is present. If they have a scar at the wrist, they have a radiocephalic fistula, which is a connection between the radial artery and the cephalic vein. If they have a scar at the elbow crease, then they have an upper arm brachiocephalic AV fistula. And if they have a long scar extending from the armpit or the axilla to the elbow, they have what's called a transposed brachiobacillic AV fistula. For extra credit, you could perform something called an arm elevation test. This involves raising the axis arm. A normal response, when you raise the fistula above the head, the fistula should collapse. If the fistula does not collapse, that if it remains distended, it suggests that there is something that's preventing the blood from leaving the arm, specifically an outflow stenosis. So if you look at this picture here, this arm is being raised and the fistula has collapsed. Of course, it's always important to listen to the fistula before we put a patient on dialysis. So listen with your stethoscope. The sound generated by the fistula is called a bruit and is characterized both by the auditory frequency as well as the duration. The bruit over a well-functioning fistula is low-pitched, it's soft, it's machinery-like rumbling sound. It's generally loudest where the scar is. That's the site of the arterial anastomosis. If it is a high-pitched sound, that suggests a stenosis. Third step involves feeling the fistula or palpating it. What we're feeling for is something called a thrill. A thrill is a palpable vibration over the fistula that's related to the blood flow. Normally the fistula is soft and compressible and has a continuous vibration, which we call a systolic and diastolic thrill. So if you palpate the fistula along its entire length up to the chest and you feel something like a pulsatile thrill, or the fistula is very firm, or the thrill is not continuous, that is, you hear it but then it goes away, so you lose the diastolic thrill, all of those findings can suggest an outflow stenosis. All right, there are a couple more important components of the pre-dialysis assessment. I find value in asking patients if they have any symptoms that concern them. For example, do they have shortness of breath or chest pain, any lightheadedness or dizziness, say after the end of their last dialysis session, maybe we removed too much fluid. Has the patient had any headache or blurred vision? Any GI symptoms, nausea, vomiting, or maybe loss of appetite that could translate into soft tissue weight loss and the need to reduce their dry weight? Has the patient had any blood in the stool, in which case we may want to hold their heparin? How about fever or chills to suggest infection? Just as important is establishing rapport with the patient. Get to know the patient, address him or her by name, ask him or her about grandchildren or work or what they did that day. Build trust with the patient and they are more likely to listen to your advice. It also helps relax the patient when you chit-chat, particularly if the patients are new to dialysis and are scared about the procedure. And it also helps convey the correct impression that we care about how they are doing. Education is also an important part of the pre-dialysis assessment. Give them feedback for example, on how they wash their fistula. Say, hey, great job. Or remind them of the importance of taking their dietary phosphorus binders. And of course, you can do it in a positive way. For example, if they're eating on dialysis and have their binders next to them, you can tell them, oh, great job for remembering to bring your binders with you while you eat this meal. If they bring in fast food, it's a good idea to maybe talk about sodium and potassium restriction. If they gained 5 kilos, a great opportunity to talk about fluid management. And of course, it's always good to encourage our patients to exercise. It's important to go over any medications that might be relevant to the dialysis procedure. For example, if the patient often has intradialytic hypotension, it's a good idea to ask the patient if he or she's been taking their blood pressure medications before dialysis and suggest otherwise. It's a good opportunity to find out if any intervention needs to be performed. So, for example, notify the nephrologist for any change that might require modification of the dialysis prescription. If, for example, clotting has been a problem, request a heparin adjustment. And if the patient's undergoing a transplant evaluation, ask them for an update. Hey, how's the testing going? Any word from the transplant facility? Encourage them in that process. All right, let's review what we've learned. The pre-dialysis assessment is important in caring for dialysis patients. We want to use it as an opportunity to confirm the appropriateness of the dialysis prescription, particularly with respect to volume status and dry weight. Of course, we want to ensure patient safety and avoid complications. For example, it's important to avoid extremes of blood pressure, such as very high blood pressure before dialysis or intradialytic hypotension. The assessment is an opportunity to review their symptoms and make sure they are tolerating the procedure and overall feeling well. So, for example, ask them about shortness of breath or chest pain or cramps or nausea, vomiting, or dizziness, lightheadedness, any symptoms that might be related to dialysis or volume overload. Good idea to examine the access before needles are placed. And as a side, it's very difficult for nephrologists to come by afterwards and examine the fistula once needles are in the arm. So you guys are in a unique position to examine their access. We want to use it as an opportunity to provide education about medications, diet, fluid, potassium, phosphorus, importance of medicines, transplant evaluation. And finally, we want to establish rapport with the patients. Patients do better if they feel cared for and are more likely to attend dialysis and follow recommendations. It's time for the monthly quiz to see if you all were paying attention. Question number 1. What are 3 signs of volume overload? That's right, there are several. Lower extremity edema, distension of the neck veins, or so-called jugular venous distension, crackles or decreased breath sounds, or wheezing, or a fast respiratory rate, i.e. tachypnea, S3 gallop, or murmur, among others. Question number 2. Based on the scar that you see, what kind of fistula is this? That's right, this is a transposed brachiobasilic AV fistula. So this is where the vein was. They transpose it, which means to move the fistula so it's more convenient for you all to put the needles in. But this long scar from the armpit all the way down to the elbow, that's a transposition scar. So you know that's a brachiobasilic AV fistula. What pathology is seen on examination of this fistula? That's right, this fistula here is abnormally widened. We call that an aneurysm. And if it gets really wide and the skin overlying gets shiny and thin, there is a risk of rupture. Question number 4, blood pressure in a patient is 230 over 120. What is the likely cause of hypertension? right, volume overload. High blood pressure is an important clue to a patient's volume status, and high blood pressure in a dialysis patient almost always is secondary to volume overload. Final question. Name 3 goals of the pre-dialysis assessment. That's right. So confirmation of the appropriateness of the dialysis prescription, say for example the accuracy of the dry weight, ensuring the patient's safety, avoidance of complications such as bleeding, providing patient education, establishing rapport with the patient. This concludes the February 2024 in-service for the Northwest Kidney Center. Thank you so much for your attention. Thank you for your excellent service to this organization and to all of our patients. This is Andy Brokenbrough signing out until next month.